So good evening, everyone. Am I audible?
Yes, Fauzia, you're audible. I think we can wait for 2 to 3 minutes more
Okay, ma'am. Sure.
before we start.
Yes, ma'am.
I think we can start, Fauzia.
Okay, ma'am.
So, a very good evening to all. Greetings from SGPGI Lucknow. Today, Dr. Fauzia would be presenting a randomized control trial regarding weaning from CPAP alone to CPAP to HHFNC in units. So, this study has been published this year in July. So, she would be presenting this trial in detail. So I request everyone to maintain the online decorum of the online presentation and keep themselves muted during presentation. And we can discuss the questions after the session is over. Thank you. You can go ahead, Fauzia.
Sure. So good evening, everyone. Myself, Fauzia Farat, first year DM Neonatology resident at SGPGIMS Lucknow. I will be presenting my topic under moderatorship of Dr. Anita ma'am, additional professor, Department of Neonatology, SGPGIMS Lucknow. So today's topic is a randomized trial comparing weaning from CPAP alone with weaning using heated humidified high flow nasal cannula in very preterm infants, the CHiPS study. So the study was published in British Medical Journal on July 18, 2022. It was a single-centered, non-inferiority, randomized control trial which was conducted in NICU, Middlemore Hospital, Auckland, New Zealand. So CPAP is the mainstay of non-invasive respiratory support in neonatal intensive care units. Benefits compared with mechanical ventilation include lower rates of death or BPD at 36 weeks of PMA. Complications include air leak and nasal septal damage. That is why early weaning from nasal CPAP is very important. So weaning from CPAP will always be judicial because weaning too slowly as well as weaning too rapidly, both of them have adverse effects. Like weaning too slowly will lead to increased duration of exposure to oxygen and can cause chronic lung disease. Similarly, weaning too rapidly can cause atelectasis, loss of functional residual capacity and inflammation. And there remains a lack of consensus over how best to wean from CPAP. So what are the weaning options? Weaning options include immediate removal of nasal CPAP at a predetermined pressure or removing nasal CPAP for a number of hours each day with increasing time off, or it can be done by stopping nasal CPAP and starting high flow nasal cannula or cycling infants between different modalities of non-invasive support. So what is already known? The CPAP is the mainstay of non-invasive respiratory support in NICU. It does come with some complications, including air leak and nasal septal damage. Early weaning from NCPAP is very important, but the best way to wean remains unclear. So what are the prior experiences or evidences? There were 4 previous RCTs before CHiPS trial, but the results were variable. Like one study was done by Tang et al. That was published in 7th October 2015. It was RCT of weaning strategies for preterm infants on nasal continuous positive airway pressure. And they concluded that use of high flow nasal cannula may be effective at weaning infants from nasal CPAP, but did not reduce duration of respiratory support or time to full suck peaks. Similarly, another study done by Badi et al. It was study on high flow nasal cannula as a method for rapid weaning from NCPAP. They concluded that weaning from nasal CPAP to high flow nasal cannula could decrease the duration of oxygen therapy and length of hospitalization in preterm infants. Then a study done by Abdul Hadi et al. On early weaning from CPAP to high flow nasal cannula in preterm infants is associated with prolonged oxygen requirement. They concluded that weaning preterm infants from nasal CPAP to nasal cannula is associated with increased exposure to oxygen and longer duration of respiratory support. So, according to this study, it doesn't support nasal weaning using heated humidified high flow nasal cannula. Then another study was done by Sun Seward et al. And they concluded that the time to wean off CPAP using heated humidified high flow nasal cannula was not different from when weaning directly from CPAP. So the prior 4 RCT, they have variable result. So coming to CHiPS study, the primary objective was to determine whether weaning from nasal CPAP using heated humidified high flow nasal cannula was non-inferior to weaning using nasal CPAP alone in relation to time on respiratory support. So coming to the PICOT format for developing specific research question, the population were preterm infants less than 30 weeks of gestation at birth who were stable on nasal CPAP for at least 48 hours on a CPAP pressure of 6 centimeter of water. Then the intervention was weaning from nasal CPAP using heated humidified high flow nasal cannula. The comparison group was preterm infants who were weaned off from nasal CPAP alone, and the outcome of interest was time on respiratory support from randomization to 72 hours of respiratory support or 36 weeks of post-menstrual age. Time frame was until weaning is completed. Coming to study methodology. So it was a single-centered, non-inferiority, randomized controlled trial which was conducted in NICU, Middlemore Hospital, Auckland, New Zealand from 2015 to 2019, and 120 preterm infants less than 30 weeks of gestation at birth who were stable on nasal CPAP for at least 48 hours at a pressure of 6 centimeter of water were recruited. So ethics approval, the study was approved by Northern Auckland Health and Disability Ethics Committee. Participants gave informed consent to participate in the study before taking part. Coming to sample size, so it was calculated by bootstrapping method. So they found that in order to have a power of 92% and a non-inferiority margin of 15%, at least a total of 100 infants had to be enrolled to conclude non-inferiority of weaning time between the two methods of respiratory support. And as it was a non-inferiority trial, so they were checking a single tail of standard normal curve. That is why they took p-value of less than 0.02. Block randomization was done by computer-generated sweeps, and allocation was done using sequentially generated sealed opaque envelope. Coming to inclusion criteria, preterm infants less than 30 weeks of gestational age who were on bubble CPAP at a CPAP pressure of 6 centimeter of water for at least 48 hours provided stability criteria. And the stability criteria were no requirement for oxygen supplementation, respiratory rate of less than equal to 60 breaths per minute, no significant desaturation defined as saturation is PO2 of less than 80% or bradycardia defined as heart rate less than 100 beats per minute requiring bedside intervention. Coming to exclusion criteria, neonates who had previously been off respiratory support for more than 7 days. Because requirement of respiratory support beyond 7 days cannot be attributed to weaning failure. And neonates who had significant congenital heart disease, surgical conditions, chromosomal abnormalities, genetic syndromes, or other major congenital malformations. So coming to primary outcome, the primary outcome was the duration of respiratory support in hours from randomization until weaning was completed. Coming to secondary outcome, so we did a subgroup analysis of the duration of respiratory support for infants less than 27 weeks of gestational age, then incidence of chronic lung disease, nasal trauma using modified Fisher nasal trauma grading, age of first sucking feed, and age when full sucking feeds was achieved, type of feeding at discharge, and neonatal morbidities like retinopathy of prematurity and intraventricular hemorrhage. So coming to weaning protocol, so after a block randomization, the babies were randomized either into nasal CPAP group or heated humidified high flow nasal cannula group. In both the groups, babies were weaned over a period of 96 hours and they were shifted to room air on day 5. And every day during this time period, babies were assessed for respiratory instability 24 hourly at 12 p.m. midday. So in nasal CPAP group, the babies were started on weaning was started at a CPAP pressure of 6 centimeter of water, and provided the stability criteria was met, it was continued for 48 hours. Then it was tapered to 5 centimeter of water, provided that the stability criteria were met. Then it was tapered to 5 centimeter of water for next 48 hours, and the babies were shifted to room air on day 5. Similarly, on heated humidified high flow nasal cannula group, babies were started at a flow of 6 liters per minute for initial 24 hours. Then they were assessed for respiratory stability, and then the flow was tapered every 24 hourly, like from 6 liters to 4 liters to 3 liters to 2 liters before shifting to room air. So study commenced at 12 midday on the day of randomization, and the weaning took over a period of 96 hours. So prior to randomization, infants received routine clinical management, primarily bubble nasal CPAP using Hudson binasal prongs with humidification. Fisher and Pickel 950 humidifier was used. Airway suctioning occurred 4 to 6 hourly as required, and all infants in the study received caffeine citrate. So coming to weaning protocol. So after blocked randomization, the babies were randomized either into group 1, that was CPAP group, or group 2, that is nasal heated humidified high flow group. In both the groups, as discussed earlier, the babies were weaned over a period of 96 hours. Then during weaning, whenever there were failure or destabilization, the flow or pressure, like in CPAP group, the pressure was escalated. For example, when there was treatment failure on 6 centimeter of water, like desaturations or bradycardias or respiratory rate of more than 70 beats per minute, rescue CPAP was started with a CPAP pressure of more than 6 centimeter of water. Similarly, when tapering CPAP pressure, when treatment failure was there on CPAP pressure of 5 centimeter of water, the CPAP pressure was escalated back to previous pressure, that was 6 centimeter of water. And when there was treatment failure while on room air or while off CPAP, then the babies were restarted weaning from a CPAP pressure of 6 centimeter of water. Similarly, in heated humidified high flow nasal group, when there was treatment failure on a flow of 6 liters per minute, initially the flow was escalated to 8 liters per minute for 48 hours. And despite of increasing flow, when there were desaturations or bradycardias or respiratory rate of more than 70 beats per minute, rescue CPAP was started at a CPAP pressure of more than 6 centimeter of water. And when there was treatment failure on a flow rate of less than 6 liter per minute, again the flow rate was escalated to previous flow. Like in case of failure at 3 liters per minute, it was escalated to flow of 4 liters per minute. And when the treatment failure while off or on room air, again the baby were restarted weaning from a flow of 6 liter per minute. Coming to failure criteria, those were 6 desaturations and associated bradycardias over 6 hours requiring bedside intervention, or any one of the following, like 6 desaturation over 6 hours, 1 episode requiring intermittent positive pressure via TPs, or respiratory rate more than 70 beats 70 per minute consistently for 30 minutes. Coming to analysis, the primary outcome was analyzed using a per protocol analysis. So they used survival analysis and used per protocol analysis for primary outcome analysis in order to show nasal heated humidified high flow weaning to be non-inferior to nasal CPAP weaning. The upper limit of 95% confidence interval in nasal heated humidified arm, it would need to lie within the mean plus 15% of non-inferiority margin of the nasal CPAP weaning time. And instead of using hazard ratio, they have used restricted mean survival time or RMST comparison to analyze the primary outcome. So coming to baseline characteristics, the baseline characteristics were very similar in both the groups. Coming to consort diagram, a total of 204 babies were participated. Out of those, 84 babies were excluded, 38 were not meeting inclusion criteria, 36 parents were declined to participate, 10 babies were transferred to other hospital. So out of 204 babies, 120 babies were randomized and allocated to either nasal CPAP group or nasal heated humidified high flow nasal. Then again, for subgroup analysis, these groups are stratified into less than 27 weeks of gestational age or more than equal to 27 weeks of gestational age. On follow-up, there was one loss to per protocol on follow-up in nasal CPAP group, whereas there were 3 loss to follow-up in nasal heated humidified high flow group. So as per protocol analysis, 60 babies were analyzed in nasal CPAP group and 56 babies were analyzed in nasal heated humidified. 56 babies were analyzed in nasal heated humidified group. So coming to
class चल रहा
so they have used a survival analysis for primary outcome. So on x-axis we have time in hours. On y-axis we have proportion before event. So they have used time to event analysis. The black curve represent the CPAP group and the gray curve represented the heated humidified high flow nasal group. And as the two curves are intersecting, it means they are a common point of interest. So that is why they have not used hazard ratio and they have used restricted mean time interval. So they have used restricted mean time interval. Using per protocol analysis, they found that in nasal CPAP group, the restricted mean time was 401 hours with a 15% non-inferiority margin was 60 hours. That is why the upper boundary of non-inferiority margin would be 461 hours. And the restricted mean time for nasal heated humidified high flow group was 375 hours. That was within the upper boundary of non-inferiority margin. That was within 461 hours. So on the basis of this result, they concluded that weaning using nasal heated humidified high flow was non-inferior to weaning using nasal CPAP. But however, when they did a subgroup analysis in less than 27 weeks of gestational age, they found that the restricted mean time in nasal CPAP group was 304 hours and the upper boundary of non-inferiority margin was 350 hours. And the restricted mean time for nasal heated humidified high flow group was 362 hours, which was outside the upper boundary of non-inferiority margin. It means in nutshell, they have concluded that overall nasal heated humidified high flow, weaning using nasal heated humidified high flow is non-inferior to nasal CPAP, but they cannot conclude this result in less than 27 weeks of gestational age. The primary analysis was done as per protocol analysis. However, they have also done intention to treat analysis, and in intention to treat analysis, they also found that the mean time that was 390 hours in nasal heated humidified group was within an upper confidence interval of 435 hours. So in both per protocol analysis as well as by intention to treat analysis, they found that weaning using heated humidified high flow cannula was non-inferior to weaning using nasal CPAP. So coming to secondary outcomes, majority of secondary outcomes were similar in both the groups, except for 4 outcomes. One was treatment failure occurring during 72 hours of respiratory support. The treatment failure was more in nasal CPAP group. It was in 29 babies out of 61 babies, around 47.5%, but it was not statistically significant. Similarly, the requirement for escalation of flow was more in nasal heated humidified high flow group, but again, it was not statistically significant. The incidence of chronic lung disease was more in nasal CPAP group. Similarly, as expected, the nasal trauma was less in nasal heated humidified high flow cannula. Coming to strength and limitation, the strength were clear weaning algorithm, predetermined failure criteria, inclusion of infants with a gestational age of less than 27 weeks, and ability for nasal heated humidified high flow groups to be rescued to nasal CPAP. Limitations were small sample size of infants less than 27 weeks of gestational age. It was a single-centered NICU study. Weaning occurred at a set time, like 12 p.m. every day. And 15% of study infants were not able to be weaned from support during the study week. So as we have discussed, there were 4 previous RCTs. Abdel Hadi et al. And Badi et al. Focused on duration of oxygen requirement and included infants born more than 28 weeks. Tang et al. Reported no significant difference in days on respiratory support when nasal heated humidified high flow was used to wean from nasal CPAP. And Sun Seward et al. Reported that time to wean off nasal CPAP with the use of nasal heated humidified high flow cannula was not different than weaning directly from nasal CPAP. So what is the added value of this study? Weaning from nasal CPAP using nasal heated humidified high flow cannula was non-inferior to weaning from nasal CPAP alone in stable, very preterm infants when using strict weaning and failure criteria. So it can be used as a viable weaning tool. So coming to critical appraisal for literature, the CASP checklist. Did the study address a clearly focused research question? Yes, they had a clearly focused research question. Was the assignment of participants to intervention randomized? Yes, they have done a block randomization where all participants who entered the study accounted for at its conclusion. No, because they did a primary per protocol analysis. Although they have done intention to treat analysis also, but primarily it was a per protocol analysis. Were the participants blind to intervention they were given? No, because it was a comparison between weaning using nasal CPAP or weaning using heated humidified hypronasal cannula. So investigators cannot be blind. Were the study group similar at the start of the RCT? Yes, they were. The baseline characteristics were very similar. Were the effect of intervention reported comprehensively? Yes, they have mentioned power. They have mentioned p-value. So it was reported comprehensively. Was the precision of estimate of the intervention or treatment effect reported? Yes, they have mentioned confidence interval. do the benefit of the experimental intervention outweigh the harm and costs? This is we can't tell because it can be different in different settings because they have not done any uh, cost effective analysis. Can the result be applied to your local population? Yes, it can be applied to our local population. So coming to consort checklist, title and abstract, they have a identification as a RCT. Yeah, there was identification as RCT trial in title. They had a structured summary of trial design, method, result, and conclusion. And the scientific background as well as rationale was explained. And they have a specific primary objective. They have described the trial. It was RCT and non-inferiority trial. They have mentioned the eligibility criteria. The intervention for each group was described. And they have also completely defined the primary and secondary outcomes and how to measure these outcomes. And they have defined sample size and they have calculated it from bootstrapping method. And they have done type of randomization was block randomization, and they have mentioned it. They had a table showing baseline demographic and clinical characteristics for each group, for each primary and secondary outcome, and result for each group. They have defined 95% confidence interval, and they have described limitations of trial. They have described the external validity and registration number and name of the trial registry, as well as where the full trial protocol can be accessed. These are mentioned. Sources of funding and other supports were also mentioned. So this is the end of my presentation. Thank you.
Thank you very much, Dr. Fauzia. So uh, the questions and comments are invited for the same. One can ask by unmuting themselves, or they can put the question in the chat box. So if there are no questions or comments, we can close the session. Dr. Fauzia, I think there are no questions. So
Yeah.
you can close the session.
Okay.
Hello, ma'am.
Yes, please go ahead.
Sorry, ma'am. Good evening. Ma'am, can you please explain why was this RMST used? Why was not the hazard ratio? Okay, once again.
Yeah, in this study, they have used RMST because usually we use hazard ratio. That is, hazard ratio is the slope of the curve, right? So whenever two curves are intersecting, we have common point of interest. Like in this curve, when we see the two curves, they are intersecting at two different points. So we cannot use hazard ratio in this aspect. And the second thing is that whenever we analyze time to event, so the RMST is the area under curve. So it includes the whole follow-up time. That is why RMST is a better predictor as well as better parameter to be used in case of time to event analysis.
Oh, okay.
So this questions the other, this answers the other question which is put by Dr. Preeti in the chat box. So if there are any more questions regarding the way of the statistical analysis, we would be happy to answer that.
So the question is how to know hazard ratio in survival analysis. So we usually calculate the slope of the curve, and it is more commonly used whenever we assess the mortality or what is the survival period. Like in case of cancer survival patients, but in case of time to event intervals, we most commonly we use RMST.
Are there any more questions? It's okay, Fauzia, you can close.
Okay.
I hope there are no more questions.
Okay. Sure.